Hello. Today we will be talking about ocular manifestations of systemic diseases, which is a very important topic because a lot of the problems in our body, a lot of the diseases in our body also affect your eyes. And sometimes it's the eyes where you can find the first few signs of this disease. And that is particularly useful because the eye is basically a window. We've probably heard of the term the window of the soul, but the eye is an actual window because it's the front part, the cornea, is transparent, the lens is transparent, and from there you can see the retina where all the blood vessels are. And this is the only area of the body where you can actually see the blood vessels. If you think that you're seeing the blood vessels when you look at your arms, those are actually the different colors because the skin is still covering your blood vessels. You can't actually see the blood vessel, but through the eye, you can see the blood vessels in the retina, and from there you can judge the macro, even microvascular changes and see if it's becoming already pathologic. It will give you a sign, it will give you a clue, and from there you can probably help the patient either get diagnosed early or control his diagnosis or even monitor the progression of his disease. Now, a comprehensive eye exam can give you clues where you can identify which problems are occurring. So, not just the retina, not just the blood vessels, but also other parts of the eye will also give you very important clues. For example, in general examinations, patients are usually examined as through the color of their eyelids. It gives the examiner a clue whether the patient is already developing anemia. So let's start with something that is not usually discussed, which in this case is the nutritional deficiencies, problems in the patient's nutrition. So let's start with some of the basic. If your patient has a deficiency of vitamin A, it would usually occur as um, a problem we call serophthalmia. Now, if it's vitamin B1, which is also known as thiamine, it can cause a corneal anesthesia, meaning the cornea becomes a little numb. It becomes less feeling, and there is conjunctival and corneal dystrophy, and even an acute retrobulbar neuritis, which is basically a problem of the optic nerve behind the eyeball. If you have a problem with vitamin B2, also known as riboflavin, it can produce photophobia and burning sensation in the eyes, basically because your conjunctiva is irritated and your cornea in such that it is very much irritated has already started to grow abnormal blood vessels. In vitamin C deficiency, you may have hemorrhages, especially in the conjunctiva, the eyelid, anterior chamber, retina, and even in the orbit. Also, there is a delay in the wound healing of the patient, which is a very common phenomenon with patients who have vitamin C deficiency. Now, in vitamin D deficiency, you may have problems as a cataract formation in the zonular area. You can have papilledema or the swelling of the eye of the optic nerve or optic disc, and there is increased lacrimation. The patient or your patient is almost always tearing, their eyes are always watery. Now, serophthalmia, which is associated with vitamin A, is such a um, big problem as identified by the World Health Organization that they already came out with a classification for it. It ranges from XN all the way to XF. So XN, which is night blindness, or the patient starts to complain that when it becomes dark, they also have a very hard time to see things. they start to have conjunctival cirrhosis, X1, X, and XB, or vital spot. We'll show you this later. Patient could also have problems in the cornea, and we label those from X2 to XS. And later on, if you have a problem with the fundus, we call it XF or a xerophthalmic fundus. I'll show you more about this later. So let's start with night blindness. It's basically one of the earliest symptoms of xerophthalmia, especially in children. These are areas where vitamin A is not very common, usually in mountainous area where they have their choice of food is very limited. You don't usually see this in urban areas. However, you can also see this in patients or children who are very picky eaters. It has been a common phenomenon right now that we have a lot of children who will eat only what they want, the things that they want, and they refuse or will refuse to eat anything that they don't decide as delicious. So some of this will be vegetables, very commonly vegetables. So you can get this by actually talking to the relatives or the guardians and then telling them or asking them about the patient's problems, especially at night. When you turn off the light, the patient is practically blind. That's usually the comment. Or when it becomes night, the patient just stays at home, stops playing because they can't see their surroundings, or complain that they have very difficult time looking at areas where there is very little light. Now, X1A or conjunctival cirrhosis, it consists of one or more patches of dry, lusterless, non-wettable conjunctiva. So lusterless means there's no shine. When you look at your patient's conjunctiva or the white part of the eye, it's almost always shiny because it's wet, it's moist, so it's reflecting light. So it's we call more a shiny conjunctiva. Now this patches almost always involve the area in between the eyelids, in between the lower and the upper eyelids, and usually in the outer part, and well, sometimes in the nasal part, but it's almost always in the middle portion where the eyelids are actually meeting. We call that the interpalpebral area. Now this is how it looks. If you notice, there's a small patch at the side of the patient's cornea. There's that small patch that's actually mottled. It doesn't look shiny. It actually looks very dry. And on a closer examination of some patients, especially if it becomes larger, you will see that this patch will actually grow the more that they are deprived of vitamin A. Stage X1B or Bitot spots is usually easier to remember because you just use the letter B, first letter in the word Bitots, and it's basically an extension of the process that you've seen in the previous stage. It's raised, silvery white, foamy. It's basically a patch of keratinized epithelium that's in the bulbar conjunctiva, usually in the area in between the eyelids, and it's bilateral and usually temporal, or usually towards the side of the ear. So this is how it would look. It looks like a foreign body. However, it's not. It's really part of the conjunctiva, and it looks like it's a foam foreign body that's stuck on the eye, but it's actually a keratinized epithelium. Some would be not that obvious, especially if it's been going on for some time, and it would look like this. So if you see things like this, especially in children, especially since they've been exhibiting signs of night blindness or difficulty seeing at night, then you probably will have a very good indication that you may need to treat your patient for vitamin A deficiency. Now, X2 means that the cornea has already been affected. It is the earliest stage in the cornea would be punctate keratopathy, which usually begins in the lower nasal quadrant. Then the eyes become hazy, granular, pebbly, and it looks very dry, similar to what you've seen in the conjunctiva in the earlier stages. Now, the cornea that would be involved looks like it looks dry and it's not shiny. Normally, your cornea should always be shiny because it's always wet with tears. And this is how it looks when you're looking at a patient with corneal cirrhosis. So you notice that the cornea looks very, very dry. Patient would be complaining of tearing and also look for night blindness. Now, the next two stages, 3A and 3B, would either have a corneal ulceration and keratomalacia. There would be stromal defects that occurs in the later stage due to the necrosis, and it takes several forms. Small ulcers, 1 to 3 millimeters, would occur peripherally. They would be characteristically circular, with steep margins and would be sharply demarcated. Now, large ulcers and areas of necrosis may usually extend centrally or sometimes involve the entire cornea. And you need to um, treat these patients very, very fast. Don't wait, don't linger, because you might lose the eye if you wait for a long time. If the defect is usually about a third of the cornea, you could still recover the eye and some useful vision. But if it goes more than 1/3 of the corneal surface, your vision would be compromised even if you recover the eyeball. Now, if it becomes larger, especially in X3B, usually this would result in blindness. Sometimes we just call it functional blindness, meaning that the patient cannot see well enough in that eye to be able to function or do their daily activities. And this is how usually it looks. So you can see the ulcer in the lower nasal area. And if you are fast enough, you may still be able to recover the cornea, and if some of them are not really extensive, you will not be able to recover them, like in this boy. Now, corneal scars would be labeled as XS. So again, scars with XS, and the stromal defects which healed would usually result in having scars, sometimes lighter, sometimes very dense, and the sizes would also vary, and hopefully you're basically hoping it will not hit the pupillary area. So scars in the area of the pupil would very, very much compromise the vision of your patient. Now, the fundus can also be affected. Now, it's characterized by tropical seed-like raised white lesions and scattered uniformly at the back part of the fundus, and it would look like this. Small white, it looks like seeds at the back of the fundus. Again, when you see this, patient would also be exhibiting signs of night blindness. Now let's talk about infections. Infections like measles usually affect also the eye. Usually the affected part of the eye would be the conjunctiva. There's going to be swelling. You'll probably have coplic spots in the conjunctiva, similar to what you see inside the mucus of the mouth. You may have corneal ulceration, optic neuritis, and retinitis, although the last two are not that common in terms of measles. But conjunctivitis would be very, very common in patients with measles. Now, German measles or rubella would present with um, with also catastrophic problems, especially since this problem happens during gestational period of the baby when they were still inside the mother's womb. You may have congenital microphthalmos, you may have cataracts, you may have glaucoma, chorioretinitis, or optic atrophy, although the most common that you will see is cataracts. The patients with rubella would also have problems in their heart and sometimes would have smaller heads compared with normal patients. This is a patient who had rubella, uh, congenital rubella, and you note that the patient had several problems, not just on the eye. You note probably would notice that the patient is wearing hearing aids. There's left esotropia, that's the inward deviation of the left eye, but in your picture it would look like it's in the right eye. There's um, size difference between both eyes. The left is actually smaller, and the patient has cataracts. The retina would also show what we call salt and pepper retinopathy, small dots of white, small darts of black, which is a rubella retinopathy. Now, patients with whooping cough would also present with some eye problems. For example, patients, if they keep coughing, especially whooping cough, are very, very loud coughing from the kids, and you would have bleeding in the subconjunctival area that you can see on the picture on your left, and sometimes orbital hemorrhages, and sometimes it's bad enough that it's pushing the eye forward. The picture in the middle would show that the bleeding in the conjunctiva is not just in the eyes, it's already infiltrated into the eyelids. And usually it's because of the pressure exerted by the patient's very, very loud and very, very forceful coughs. AIDS became a little more common in the 1980s, and it's caused by a virus, the human immunodeficiency virus. It produces a lot of retinal problems. It develops from occlusive processes. Some of the blood vessels became blocked, and usually it's because of the toxic effects of the virus on the blood vessels themselves. And some of the immune complex would coalesce and be deposited on the precapillary arterioles. Now, it's usually characterized by nonspecific lesions. There are multiple cotton wool spots occurring in about half of all the cases, and there's superficial and deep hemorrhages occurring in about 15 to 40% of the cases. Microaneurysms and telangiectasia may also be seen, but they're not that common. So, looking at the patient's retina uh, would actually tell you that they may have an infection problem. This is not very, very specific for AIDS, meaning if you see a picture like this, it doesn't really ring that it's already it's automatically AIDS, but you need to attach this with some of your investigations regarding the history of the patient. And if you see a patient with this kind of a fundus, you ask the patient to also be screened for possible infections. Now, some people would also have these infections, but this is very, very common in patients with AIDS, especially those with severe AIDS. Now, these are herpes zoster ophthalmicus, herpes simplex infections, toxoplasmosis, and ocular tuberculosis, syphilis, and fungal corneal ulcers. Again, as I said earlier, you will also see this in patients who does not have AIDS, but in patients with AIDS, these are very, very common. Sometimes you will see two or even three of these cases all in just one patient. So if you see an abnormally um, large number of infections in a seemingly normal patient, one of the things that you should always consider is the patient may have HIV infection. Now, there are opportunistic infections of the eye that will become more rampant if your patient's defense system is compromised, like in AIDS. Um, for one of them is cytomegalovirus or CMV retina, which affects the retina. So we have CMV retinitis, and fungal infections become more common. Candida, cryptococcals, and pneumocystis carini would become more common in patients with AIDS. Again, if you see patients with infections that usually you see very rarely, almost always consider the possibility that the patient may have AIDS. It's not automatic. The patient doesn't automatically have AIDS because you see this, but it raises your suspicion that they may have a compromised immune system. Now, this is a CMV retinitis, also known as pizza pie retinitis. You can see the bleeding, the exudates, and once you see this, sometimes the first thing that you will think of is a cheese pizza. So in that case, again, you may need to consider the prospect of your patient having AIDS. Now, we've seen a few cases of patients who have not been diagnosed with AIDS yet, and this sometimes is their presenting symptoms. They may have recurrent infections, but they've been just linking it to problems in their lifestyle, or they've probably been exposed to a lot of uh, problems in the outside or in their work. And usually, having AIDS is one of the last things that they will consider. And if you see this in a patient who have recurrent problems, almost always have them screened for HIV infection. This is a fungal infection, pneumocystis carini. Again, very common in AIDS patient, but it's rare if you have a very healthy immune system. Some cancers are also very, very uncommon, but in patients with HIV, you see this very, very often. One of them is KAPOSI sarcoma, which is a vascular tumor that's malignant, and it may appear in the conjunctiva as multiple nodules. We'll show you later on what it means. And it could be seen in about 3% of cases with AIDS. Burkitt's lymphoma of the orbit is also seen in a few patients. Sometimes Kaposi sarcoma is one of the first signs or one of the early signs of the patient having an HIV infection. And it would look like this. It looks like a blood vessel that has burst, but it's actually a solid mass, vascular mass. So if you see this in your patient, either they've been diagnosed previously or not been diagnosed previously, if you see this in your patient, have them screened for HIV infection. Now, going to endocrine and metabolic disorders, having problems with gout would also sometimes present with problems in the eye. Your patient would probably have episcleritis, scleritis, and uveitis. These are basically inflammation in the white part of your eye or the inside of your eye, and it would be very helpful if your patient have uveitis or you've diagnosed a patient with uveitis, that you also start asking them for pain in their joints. And usually, one of the more common reasons for this would be gout. Diabetes mellitus, one of the more talked about diseases as far as our health is concerned. Now, your eyes are very, very commonly involved in diabetes. That the three most common systems in your body that are involved with diabetes are your eyes, your kidneys, and your nerves. Those are the most common. And structure-wise, your eye could be affected by a diabetes we'll break it down into the structures. In your eyelids, you can have santilasma, or you can have recurrent sty or internal hordeolums. In your conjunctiva, you may have telangiectasia, which is your blood vessels are becoming corkscrew. There's sludging of the blood in the conjunctival vessels and some conjunctival hemorrhage. Your cornea would have pigment dispersion, especially at the back of the cornea. You'll have decreased corneal sensations, usually due to a problem with your trigeminal nerve. You may have punctate keratopathy, Descemet's fold, higher incidence of infective corneal ulcers. Remember, uh, your defense mechanisms and your healing mechanisms are compromised in patients with diabetes mellitus. And they may have delayed epithelial healing due to the abnormality of the epithelial basement membrane. Usually, a small scrape in your conjunctiva, on your cornea, would heal in less than 24 hours. With diabetes, it takes much longer. In your irises, you may see blood vessels. You never should see blood vessels on your iris. So if you see blood vessels in your iris, that's already pathologic. We call it rubeosis iridis, or a nevascularization of the iris. Your lens may show snowflake cataracts in patients, especially in insulin dependent diabetes mellitus. You may have posterior subcapsular cataracts, again, very common, especially in patients with either diabetes or steroid intake. You will also notice an early onset and early maturation of the senile cataracts. Patients as young as 40 or 50 years old already starting to develop cataracts, and the cataracts of these people would usually mature much, much earlier and faster than patients without diabetes. We've actually seen patients go from an immature cataract to a fully mature cataract in a matter of months, just because their diabetes mellitus is very, very much uncontrolled. Now, in your vitreous, you may see bleeding or fibrovascular proliferation secondary to diabetic retinopathy. And your retina, the ones that usually is scanned or checked when you have diabetes, will have either diabetic retinopathy or leukemia retinalis. Now, that doesn't end there, because your pressure could also increase because of diabetes mellitus, and there is an increased incidence of primary open-angle glaucoma in patients with diabetes. Neovascular glaucoma usually is now more common in patients with diabetes, because the retina, the diabetic retinopathy, would produce a severe hypoxia event, and that would actually involve the rest of the eye, including the iris, leading later on to neovascular glaucoma. If they have, sometimes there's hypotony in patients with diabetic ketoacidosis. It's because of increased plasma bicarbonate levels, and it's pulling the fluids out of your vitreous. Or sometimes you'd have optic neuritis in your optic nerve. There is now increased incidence of ophthalmoplegia, again because of the problems in the nerves of your diabetes, from your diabetes, and your refraction will change very, very often. There is a hyperopic shift in hypoglycemia and a myopic shift in hyperglycemia, because usually this sugar will find themselves going into your lens, bloating the lens, and increasing your nearsightedness. And because your lens is bloating, it's increasing, there is also decrease in your ability to read at near. Now, the truth is, a lot of diabetics will get diabetic retinopathy in their lifetime. As much as 90% of all diabetics will eventually get diabetic retinopathy. Now, as for the time that you get it, usually depends on how long you've had your diabetes. For insulin-dependent diabetes mellitus, you see it earlier. Usually, by the time you hit 5 years, you should start screening already. At 10 to 15 years, or from one fourth to about half of all diabetic insulin users will start to get the diabetic retinopathies. And by the time you have 30 years of using insulin, you will have 100% chance of having diabetic retinopathy. Now, what triggers this is not the insulin, is because patients with diabetes mellitus who needs insulin have a more aggressive type of diabetes. And if you don't need insulin, if you're one of those just taking oral medications and your blood sugar is already controlled by that, in about 10 years, you should already start having your eyes screened for diabetes. But let's get more specific than that. This is what you usually see. This is a proliferative type of diabetic retinopathy. This is actually one of the late stages of diabetic retinopathy. You can see all those small blood vessels in the background. Those small blood vessels, especially the ones the tiny blood vessels that you're seeing, are abnormal. They should not be there. Those are neovascularization, and this patient is showing a very prominent sign of NVE or neovascularization elsewhere. Now, your blood glucose, once it elevates, it damages your capillaries. There's capillary basement membrane thickening. You start to lose your capillary pericytes, and there is a breakdown of the blood retinal barrier. That means your blood vessels start to leak. Now, non-proliferative diabetic retinopathies can be classified as mild, moderate, or severe depending on what you see. Mild, that means you only see microaneurysms, so small dots of blood vessels. You see small dilated blood vessels that they look like small dots in the retina. If you only see that, that's a mild type of diabetic retinopathy. Moderate would have the symptoms of mild plus hard exudates, macular edema, or intraretinal hemorrhages. You see bleeding, you see exudates, that's already moderate. And severe would have venous bleeding, soft exudates, and proliferative diabetic retinopathy would have the neovascularization as their hallmark. They would have neovascularization either on the optic disc or elsewhere, anywhere else in the eye. If you see neovascularization in the retina, that's already proliferative diabetic retinopathy. Sometimes they will scar after repeated problems. You will see probably scars or detachment because those tractions appear because of the contractions, and they pull the retina away from the rest of the retina. They actually tear the retina apart. Now, the question now becomes, when do you need to see the doctor, or when do you need to send your patient to see an eye doctor? So, our rule of thumb is that within 5 years of diagnosis, if your patient is having a regular annual or preferably semi-annual checkup, so if your patient is having an examination every year, and that is the first time you've diagnosed them with diabetes, you can wait 5 years before sending them to an eye doctor. But if your patient have no regular checkup, you see them very irregularly, then at the time of diagnosis, send them immediately to your eye doctor for a screening. The reason being, you don't know when your patient had the diabetes And usually, the patient would have had the diabetes probably years or months before you actually saw the patient and made the diagnosis. So, whenever your patient starts to complain of visual symptoms, now you need to send them to an eye doctor, irregardless of how long they've been diagnosed. And if your patient is pregnant and with a history of diabetes, send her to have a regular checkup at least during the duration of her pregnancy. Now, how do you manage patients with diabetic retinopathy? First and foremost, you need to control the blood sugar. Okay, so that's first. And that's one of the management modalities that your patient can participate in. Give them a homework, give them a target. We're treating your eye, but you need to control your blood sugar. Treating the eye with the patient rampantly eating sweets and having a rampant blood sugar increase, uncontrolled, and very, very high increases, would actually nullify everything that you've been doing. Okay, so you need to monitor one, your patient's blood pressure, your patient's cholesterol, and your patient's hematocrit. Okay, remember blood pressure, cholesterol, and hematocrit, because um, studies show that the progression of diabetes retinopathy and other organ problems, which are common complications of diabetes, are very, very well controlled. Becomes The progression becomes less acute and more controlled if you can control the patient's blood pressure, cholesterol, and hematocrit. Now, the management of the eye would be would be highly dependent on what stage that you've been able to diagnose the patient. If it's just mild or moderate non-proliferative diabetic retinopathy, remember non-proliferative, you could just have a regular fundus exam and fluorescein angiography without intervention. If you start to have clinically significant macular edema, that means your patient's visual acuity would now be affected. You could have a grid or focal laser photocoagulation or injection of an vitreal injection of an anti-VEGF, which should take the control the um, neovascularization. Now, if your patient becomes or reaches proliferative diabetic retinopathy, the recommendation would still be a pan-retinal photocoagulation. That means you do a photocoagulation laser on a very, very large part of the retina. And if your patient already has vitreous hemorrhage and traction retinal detachment, your patient may need vitreoretinal surgery already. Tractional retinal detachment usually needs to be evaluated and treated appropriately very early. Sometimes they become worse, they enlarge, especially if the process is still very, very active. Galactosemia would be usually associated with congenital cataracts. So, um, if your patient has been diagnosed with galactosemia, check their eyes. If you are not in the habit of checking your patient's eyes regularly, try to do so, especially if you see any metabolic problems in your patients. In galactosemia, especially in usually diagnosed very, very early on, check for congenital cataracts. Homocystinuria would usually be associated with bilateral subluxation of the lens. Their lens would not be in the center. The zonules are weak, such that the lens would now be floating inside. Patient on the left, the lens is actually superiorly dislocated. What you see at the lower edge is the retina of the patient through the red-orange reflex. The one on your right it's now displaced superonasally, and the area that you see on the sides is actually the retina. The patient would have very, very poor vision. It's like wearing a pair of eyeglasses that's not in the center. You've actually, if you shift your eyeglasses towards the left, the right, up or down, and try to look through it, you'd notice that part of your vision would be compromised. It's not usable. The center might have distortion because you're now seeing the edge, not the center of your lens, and this needs a surgical correction. Hyperthyroidism, which is again is a common metabolic problem. Ocular lesions will include thyroid ophthalmopathy, superior limbic keratoconjunctivitis, and or optic disc edema. You know of a lot of the symptoms in hyperthyroidism is basically your body's metabolism kicking up into high gear. You're very very you feel very very hot. So if your surroundings are actually warmer, you feel extra hot. There will be problems in your tremors, in your fingers. You probably have gastro problems. You'll have, well, one is you'll start losing weight, which is one of the more major hallmarks of hyperthyroidism, but your eye is also affected. So we call this problem Graves' disease. Your eye is affected by your hyperthyroidism, and usually your patient will look that like they're always angry at you. Okay, so their eyes are not necessarily popping out. It could just be their eyelids, or their eyes could already start to be proptosed, or in layman's term, it could have already started to pop out. Although some patients will describe their eyes as popping out, even though it's not, just because the eyelids are retracted and it looks like their eyes are popping out. There are these are the classification for Graves' disease. The mnemonics is NOSVEX. So just memorize the mnemonic. Class 0 is no signs and symptoms. Okay, just remember when you're putting the grades, it's grades 0 to 6, not from 1 to 7. Okay, it's 0 to 6, not 1 to 7. There's a class 0, meaning there's no signs and symptoms. There's a class 1, you only see signs, which is limited to the eyelids. Either their lids are retracting. It looks, and there's a problem with the closing of their lids. Class 2 would have a soft tissue involvement, meaning you'll already start to have edema of the conjunctiva, the eyelids. It's irritated or swollen. Class 3 would be proptosis, meaning the eyes actually start to go out of the socket. It's being pushed forward. Class 4 would have problems in your extraocular muscles. Usually, your patient will complain of having double vision at this stage. Class 5 would have corneal involvement. Again, primarily because the eyes are always exposed and it becomes very, very dry. You need to be very aggressive already at this stage. And at class 6 would be sight loss, because the optic nerve has already been involved, because the eyeball itself has been pushed forward and the orbital contents have swollen. Now, there are other signs in other diseases. These are cases with high serum copper level. A Kaiser-Fleischer ring would be the picture at the bottom. The Kaiser-Fleischer ring is the brown pigmentation on the limbus. That's where the white part meets the colored part of the eye. That brown area is copper. Or you can have sunflower cataract with the picture on your right. So the cataract itself would look like a sunflower. So in these cases, these are due to a very, very high copper level in their blood. Now, your skin could also be affected, and since your skin is affected, your eye would also be involved. One of them is atopic dermatitis, very, very common in patients with very, very itchy skin. You would have associate conjunctivitis, keratoconus, and sometimes even cataracts. Atopic dermatitis would look like the one on the right. It doesn't necessarily have to be in the eyelids. It could be in an area near the eyelids, and it could cause problems like the cataract on your left. Rosacea is the redness in the skin. You have several subtypes. You could have just facial redness. You could also have the subtype 2, which would give you bumps and pimples. Subtype 3 would have already a thickening of the skin, and subtype 4, the eye would be involved. Now, usually when the eyes are involved, it's either your patient will have blepharitis, meaning the eyelashes are either swollen or infected. You'll have conjunctivitis. The white part is already swelling or getting irritated. Your patient might have keratitis or rosacea pannus. Now, these patients would also um, complain of dry eyes, and sometimes one of the earliest symptoms in these cases is dry eyes. So just look at your patients. Look for the redness, so you know you're dealing with rosacea. Now, Stevens-Johnson syndrome is a very serious problem, such that in classification of dry eye cases, there's an entirely different uh, segment devoted to Stevens-Johnson syndromes, and it's basically a hypersensitivity to drugs, in particular sulfonamides. So you look at your patient's medications. This is one of the uh, benefits of having a very, very good medical history of your patients. You always ask them, what medications have you been drinking or are drinking? And if you see sulfonamides and see problems in their eyes, tearing, then you probably could suspect that they are having Stevens-Johnson syndrome. We'll show you a severe case later on, and it is characterized by acute ulceration of the conjunctiva. Again, it's not as painful as the cornea, but pain in the conjunctiva would produce at least mild pain in the patient. And other mucous membranes in the air, like your mouth and vagina, would also have acute ulceration. Now, this ulceration is followed by cicatrizing conjunctivitis. The injury would now be um, creating chronic inflammation, and the clinical picture at this stage is the same as in ocular pemphigoid. So this is how your patients might look, or especially in the severe stages. In the earlier stages, just imagine it with less intensity of the inflammation of the conjunctivitis. But this um, type of conjunctivitis is differentiated by, if you pull the eyelids, you will see that part of the conjunctiva of the eyeball has now fused with the conjunctiva of the eyelids. Okay, the conjunctiva of the eyeball fusing with the conjunctiva of the eyelids. If you pull them like the one in this picture, you will see areas that have connected. And one of the problems of this patient is they have very, very dry eyes. Now, blood diseases will also produce problems in your eye. One of them would be anemia. So, an anemic retinopathy can occur at any etiology, as long as your anemia is severe. So, you're looking here with for retinal hemorrhages, cotton wool spots, and venous tortuosity. Again, the problems are not very specific to anemia. If you see this does not automatically say anemia, but once you see this, you almost always ask them and have their blood picture monitored, especially in this case, their hematocrit. Again, remember, one of the 3 things that you should always be checking in a patient with diabetic mellitus is hematocrit. In patients with leukemia, they may occur in forms of proptosis due to deposits of the leukemic deposits in the orbital tissue, pushing it forward. And there are leukemic retinopathy, which is common occurrence of the lymphocytic as well as myeloid leukemias. So this is a patient with a leukemic retinopathy. One thing that you should find interesting is they have the um, red hemorrhages, red hemorrhages spots would sometimes have white spots in the middle. Okay, so if you see cases like this, one of the things that you should rule out is a leukemia. Okay, so see the blood, see the hemorrhages, especially the ones at the center, and they have a white spot in the middle of the hemorrhage. Sickle cell disease would also produce eye problems with dilated conjunctival vessels and what we call sickle cell retinopathy. This is a fluorescein angiography picture of the of the retina and showing you typical sickle cell retinopathy. Lymphomas may also have ocular lesions, and we've had cases whose presenting symptom for lymphoma is actually the ones in the eye. It may produce lid and orbital deposits like what you can see here. The picture on the left and the right are um, the lymphoma deposits, and sometimes uveitis or inflammation inside the eye. It could be in front, it could be at the back. So in those cases, you need to rule out cases of lymphoma, especially if you see these um, structures at the sides of the eye. So that would be it for now. Just make sure that when you see eye problems, you also make a good examination of your patient's other systems, because their other systems would be producing symptoms in the eye, and what you've actually discovered in the eye may be a presenting symptom of the diseases which have up to that time remained undiagnosed, and you may be the reason that your patient would be able to save several years waiting for their diseases to progress, because you'll be able to diagnose it early. You probably save your patient a lot of complications in terms of the progression of the disease. Also, problems in the eye could also be used to monitor the progression of the disease. For example, checking the diabetic retinopathy in a patient who's not been seeing his endocrinologist because they sometimes they think it's not important. What's important is that they're actually having their eyes checked because they're complaining of blurring of vision. So if you notice that their diabetic retinopathy is progressing, it's getting worse, make sure that their blood sugar has already or is also being controlled. The patient could be ignoring one in terms of the other. Or sometimes your patient is just so in such a point in their life that they've not been able to take care of themselves, and when you talk to them, they would agree that this medication should be done, that this treatment should be done, or this exercise should be done. But when they get home, they're too tired, nobody's taking care of them, they have problems just feeding themselves. So your medications and treatment may not be being followed, and progression of their symptoms is one of the indications that either your treatment is not working or your treatment is not being used. So in case you have any questions, feel free to put them in the comments section below, and have a good day.